Let's start our lecture for today. First, we have our ACS Spotlight Lecture. This year will be presented by Dr. Daniel Margulies. He's the Trauma Medical Director at Cedars-Sinai Medical Center in Los Angeles, and also the Chair of the Verification Review Committee for the American College of Surgeons Committee on Trauma. Dr. Margulies.
Thank you, Dr. Hugh. Good morning, everyone. I'd like to congratulate you all on this really fantastic symposium, and 10th anniversary is very impressive. Thank you again, Dr. Hugh, for inviting me out. I got to say, this is remarkable to me that it's a packed audience today, 8 a.m., to hear about verification. It's often a painful thing, and it's like going to the dentist, really. You wake up at 8 a.m. to go to the dentist. But I am going to talk a bit about verification process. What it's for is to improve care, as you just mentioned, regarding injured patients. And I'll hopefully answer some questions. If not, please feel free to ask me any questions you have. I have no financial disclosures. I don't get paid by the college. I will be speaking about things the college presents. And I'm, like I say, no financial disclosures. But I have to say that I am biased, and I think probably everyone has some bias. I volunteer for the college as chair of the Verification Review Committee. And that's because I believe it does some good. And so there's my bias. So that's my disclosure. I'm going to talk today a bit about the screen just went here. Okay. These are the objectives, identifying the essential elements in obtaining and sustaining trauma center verification. Many of you are familiar with the process. Many of you work in trauma centers that are verified, and some that perhaps are not verified or considering verification. Some get designated through the state and verified through the college. I'm going to discuss the role of the staff across the continuum of care in attaining and sustaining trauma center requirements. The screen keeps going off. And then identify the key benefits of being a trauma center that are directly applicable to the optimal trauma patient care. Now, a little bit about the background. So the American College of Surgeons Committee on Trauma, which is one of the large committees of the American College of Surgeons. The two largest committees are the Committee on Trauma and the Committee on Cancer. And this committee was formed a long time ago, 1922. So it's been in existence a long time and has done a number of things. It's provided verification for trauma centers since 1987. And then pediatric trauma center verification commenced in 2006. And the mission is to achieve the optimal care for the injured patient. Currently, this is only done in the United States. There's some thought about sending this or helping other countries that are interested in this process. But right now, this is only in the United States. The document we use, you're probably familiar with if you're in a trauma center that's verified, and it's entitled The Optimal Care of the Injured Patient, or the Orange Book currently. And the activity is the Trauma Center Review. That's a site survey. And we use expert clinicians, trauma surgeons who are active in their program, not retired 5 years and out of touch, but someone that's actually doing trauma surgery. And we use trauma program managers as well, who ensure the consistency and adherence to the best practice guidelines and criteria set forth in this document. So There's a lot we don't know, and there are some things that we do know. What I can say is that the verification process is rigorous. It's comprehensive, and it does serve as a model in many state-based systems. Some states require it. Others use our verification process to help them with their own designation process. In pursuing verification represents, at least in my view, a level of commitment from the hospital, from the leadership, from the staff that drive the performance and outcome improvements. We do, as much as possible, try to make everything evidence-based, and this evidence persists. It demonstrates a variety of benefits, and I'm going to go through some of the most recent literature on this, but the benefits for the hospital for achieving verification include, some would argue, but I would say it includes improved outcomes, and this has been shown in multiple iterations for decreasing mortality and morbidity in a verified trauma center. It has been shown also to decrease length of stay, decrease readmissions. It tends to improve the finances of the hospital and a reduction in overall trauma cost. This was from a paper written by Dr. Brown in 2013. Now, this recent article, 2017, used NTDB data comparing 262,000 patients in verified American College of Surgeons verified centers versus 130,000 patients in non-ACS verified trauma centers. And I'm not going to go through all the methodology or details, but their conclusion were that the complications are more likely in non-ACS verified trauma centers at the extremes of age for patients with less severe injuries and for all patients with more severe injuries. So the conclusion was that trauma center verification improves outcomes for both patients and the hospital. And again, it has, in this paper, this is a separate paper in 2009, showed increase in admissions to the interfacility transfers and interfacility transfers, increase in acuity in becoming a verified trauma center, reduction in mortality, which is a theme we've seen over and over, a trend towards decrease in ICU length of stay, substantial increase in contribution to margin, again, beneficial to the hospital, net profit, and revenues overall. I'll list these references for you at the end. So the early impact of the American College of Surgeons verification at a level 1 pediatric trauma center was an article written 2016. And ACS verification at that level 1 pediatric trauma center was associated with an immediate benefit to patient outcomes. Enhanced tracking and institutional policy changes result in fewer hospital-acquired conditions or problems. So the American College of Surgeons trauma center verification versus the state designation are level 2s, 2 centers slipping through the cracks. This was an article, again, by Dr. Brown, at which he concluded that level 2 trauma centers have a disproportionately high number of mortality outliers, and that the ACS verification is a predictor of survival. ACS verification appears beneficial at level 2 centers, and that they benefited the most. So these are some of the iterations of the book that you may or may not be familiar with. The older ones are in the back. It was red, then blue, then yellow, and green. And then currently, this is the current version from 2014 that we're verifying from. Now, the process is undoubtedly not perfect, and these books do change with time. But change is difficult for trauma centers. Each time a new rule comes out, you know, every center across the country wants to be verified has to make those changes. So A lot of thought goes into what goes into this book. I think most of you, if you're in a trauma center that's involved with this process, are familiar with that orange book. That's the optimal care of the injured patient, and it goes through all the requirements that are needed. And then what the verification process is to have site reviewers go out and actually see whether the hospitals are doing that or not. And then there are some other documents that I'd like you to become familiar with if you're not. This first one here is the clarification document. And this came about because there were always questions. And anytime we put something out, there's going to be questions, well, how does this relate to my place? What about this? So questions arise, and we answer the questions as best we can. And then rather than doing that individually for each center, we'll post these as a clarification. If there's either a change to the rule or something that we can make clearer, we'll post this as a clarification. This makes it a bit difficult because now new information is coming out. So, and then it's maybe changing. So what we do is date it, and you can see right here on the bottom the date that this clarification document has come out, and that's important to pay attention to. So you want to look at the most recent clarification. This is posted online, and in addition, to make it a little bit easier, we post a change log. So in there is what's changed since the last one. So you can see highlighted in orange what the change has been and easily scroll through there. So there's three different things that you have to look at, and we realize that's cumbersome. You're looking at the book, then you're looking at the clarification document, then you're looking at the change log, and that can equal a headache. On the other hand, if you don't really have the answers to your questions and you don't know what's up to date, then that's even more of a problem. So I think it's still important to look at them all. And what we're doing right now, and I'll maybe get into this a little bit more in the future, is trying to update this whole thing and put it into a new book. Then you won't have all of these different areas you have to look at, and you'll have one place. But it is important, like I mentioned, to look at this date, because this is version 8 here in 2016, and I would say it's your responsibility, if you're in the process, to monitor that date and stay current. Your trauma program manager knows this. Your director should facilitate this, and the trauma leadership needs to be kept informed, as well as the departments that work with you, of any changes that happen that relate to them. So these are some of the resources that you have for verification. The optimal care of the injured patient, I mentioned the orange book. That was, I showed the picture of. This is the 6th edition. And I have to say there's a lot of work going on in the revision of this edition. I think that it's, in one way, too infrequent that the book gets revised, in that, it's things happen and new knowledge comes out. And as I said, it's not a perfect process, but I think as much as possible we try to be evidence-based. And if there's a reason that something should be added or removed, then we should be doing that. So we're in the process of having this book revised, and I can talk more about that if you'd like, but I think it's important. On the other hand, change is difficult, because anytime something happens, you have to, change your whole program, and we don't want too frequent changes either. Now, there are a couple of things, other resources that you have for verification: the alternate pathway criteria, which you should become familiar with, the verification change log I mentioned, 2018, and the clarification document, 2018. If you've been through this process, it starts out with a questionnaire that you fill out from your hospital, telling us about your program. And there's an interim PRQ that was put out for this book, this 2014 version, and that's been undergoing some process of improvements as well. So there's instructions on how to fill this out, and this is coming out really soon. The interim PRQ is currently for adults, level 1 adults and children only. Now, preparing your site for a visit is a big task. There's an agenda that we will send out to you telling you what we're going to do ahead of time, and whether it's a standard visit or a combined visit, meaning adult and pediatrics, pediatric alone, or a focused visit. This is another type of visit that we do. If you'd had an issue in a previous visit, and it requires a revisit, a focused review, we'll go back out and just look at the problem that you had and try to answer whether you've now brought that problem up to speed. So these focused reviews are not as detailed as the full visit. It's really focused on what the issue was identified at the prior one. There are a number of tutorials and educational things that we've been working on and are available. There is a clarification and changes in verification criteria video. There's a video on becoming a verified trauma center, how to do it, the first steps. There's a tutorial on becoming a verified trauma center, the site visit. And these are all resources that you can find at the college site that might be of help. In addition, we have a monthly trauma center Q&A webinar, and I know many of you participate, and you may know Molly Lozada, who does this monthly, and what you do is send questions in to her ahead of time, and she will address this in a monthly fashion, rather than individually to the one center sending it to this webinar. And so that's available for all to see, and that's useful also because it gets everybody on the same page, lets you know what we're doing, and you feel free to ask questions at that monthly webinar. There's also supplementary materials, guidelines, and samples that we have for you. So there's a lot of resources. There are also a lot of criteria that we have in this book, and this is one of my sort of complaints is it's a lot. If you count up them all, it's about 340 different criteria, and you have to pass them all. You miss one and that's a deficiency. So it's a lot, and this is including level 1 and level 2 centers. I think the process could be made better. I think that we could have fewer criteria, and that's one of the focuses of the current revision process. If they're redundant or in different chapters can be combined, we're trying to see if we can make that a better process, both for the center and for the reviewers. Because one of the issues that I'm trying to deal with is consistency among reviewers, between sites. One center gets dinged for this and another doesn't. That's not good. So, all the criteria should be reviewed, and if you skip some, that can be an issue. So that's an important thing. Pediatric centers have their own specific criteria as well. Now, why would anyone want to go through this? Like I said, it does sound painful, and I'll give you a few reasons here to be part of the trauma center verification. I gave you some of the literature in the beginning of the improved benefits, and we're always looking to study this as well. So number 10. So in many's view, the ACS verification process is considered to be the highest attainable standard for a trauma center. And just this goal in its own self is probably worthwhile. And then once attaining it, we say you're verified for 3 years. So things do change, and we require a re-verification after that period. But for 3 years, you can say you've met the standards. The standards have been well thought out, and are so I think that's something that's important. Now, this is some of the things that are required. A hospital-wide strategic initiative is required in the verification. And this aligns your goals with your strategy. And it's a written and demonstrable commitment from your hospital. This is one of the requirements, and it's got to be from the governing body of the hospital, the board. Also, a written statement is required from the medical staff, which is generally the medical executive committee, and it can't be just old. You can't say, well, 20 years ago, 10 years ago, our medical staff wanted to be a trauma center, and so we are. This has to be updated every 3 years, and when we verify, we look for this. So your trauma staff and medical director will be going to your medical executive committee and asking, do you still want to be a trauma center? Is the medical staff behind it? Are you committed? You know, are your specialists willing to come in? And they have a little discussion about that, and they have to decide. And so if your hospital, your medical staff, and your board are not behind it, you won't have these, you won't be verified. So I think this in itself is a strategic initiative which is important. Number 9, shared responsibility across the continuum of trauma care. And you can see this is something that's required from the Orange Book. Pre-hospital, emergency department, radiology, operating room, trauma, surgical, ICU, the med-surg floor, rehabilitation, all of these are areas that we look into. They're all touched on in the Orange Book. In addition, laboratory, blood work, social work, case management, pharmacy, emergency preparedness. This is a lot, but all of these are involved, and so you can see that it's not just us looking at the trauma surgeons, but the nurses, the trauma education, injury prevention, outreach, even the medical examiner, and performance improvement, and you can read the other things. All of these are touched upon in the review process. So it's not any one department's responsibility. It's not just the trauma division trying to make this happen, but it's something that goes across all of these areas. And you can see that here's a few more listed: the subspecialties, emergency medicine, radiology, anesthesiology, neurosurgery. They all have to come together to help take care of the trauma patient, and so these are all areas that are going to be under examination for the verification process. This includes criteria for RNs, NPs, PAs, paramedics, MICNs, trauma center staff. I think that's something that's probably sometimes forgotten because, you know, we tend to think of the trauma division as a surgical division, but it really goes through your entire hospital from the moment, even pre-hospital, to the discharge into wherever they're going. Now, what about physician requirements? This is the reason number 8 to be a trauma center. There are certain requirements for the trauma medical director. There's trauma physician liaisons required from these areas: emergency medicine, anesthesia, neurosurgery, orthopedic surgery, and radiology. And we have meetings involving all of these with requirements for their attendance at our meetings, and this is happening across the country. So to get these all together to talk about the issues involved in trauma is very useful. Again, if you didn't have this verification process, if you didn't go through this, you wouldn't have these requirements to get these folks into a room and discuss the issues as related to the injured patients. It's not easy to schedule, and everyone's busy, but I think it's important, and it's actually done. So the other thing is the trauma call panel physician response times. Everyone has a panel of surgeons on call, but we track what their response time are for different things. You know, when there's certain criteria to be in for different things, and this is something we look at as well. So to have these set out as a physician requirement is another reason. If you hadn't gone through this process, you wouldn't have these requirements. Number 7, nurse requirements. And these are also things that are laid out for both education and staffing issues for the ED, for the operating room, for the PACU, for the ICU, and these are areas that we visit when we go to do a site visit, plus areas that we ask questions about on the pre-review questionnaire. So there's these nursing requirements, and again, if you didn't go through this process, you wouldn't necessarily have these things in place. There's an orientation that's required before starting on taking care of the trauma patient. This is spelled out in the Orange Book. I'm not going to go through the whole thing and all of the requirements, but there's requirements regarding the continuing education certifications for nurses, and they must provide a mechanism to offer education to nurses involved in trauma care, so it's something you can take to your administration and leadership if they don't do this, because we feel it's important. And then one of the huge things in what we do is to look at the performance improvement process. We're not looking so much at the outcomes, but the idea is that if we have a process in place that is set and makes it available to take care of these patients, you will then take the care of the patients to the next level and identify issues in your own institution that you need to correct. And this is the basis of the performance improvement and patient safety process program. It looks a little different in every center. We do prescribe somewhat how it needs to be done, but we also leave quite a bit of variation, but it needs to be done. And this is, I think, one of the major things that the college feels very strongly about. So we're putting in place the requirement for the process. The outcomes should follow if you're looking closely and have a good process. So this entails participation in corrective action. You can't just say we had a problem. Okay, what's next? You know, you have to do something about it. So you had a problem. What are you going to do about it? And that's the basis to this performance improvement, for you to analyze your own place, figure out what you can do better, differently, and to get the resources to have that happen. So this leadership participation in the trauma operations committee is important, and this is something that the nurses are involved with. Okay, moving on to number 6, pre-hospital trauma care. So this is another requirement, as I mentioned, participate in the training of pre-hospital personnel. If your hospital's trauma center is not doing this, it's something that we have as a requirement in the Orange Book, and it's something that we feel is part of the beginning process of when these patients coming into your system, and it needs to be done properly. So if you're having issues out in the field before they even arrive, that's going to affect the patient's care, and these are things that the trauma center should be addressing. So you are involved, if you're a verified center, in the development and improvement of the pre-hospital care protocols, and this is examined when we go out for verification visits to see that this is happening. They're also involved in the performance improvement process, patient safety process. So if you identify an issue that, patient should or should not have been intubated in the field, and you identify that that was a problem or there was a lack of education, then that's something that needs to be fixed. So that's just an example of you taking the problem, going back and fixing it. And then what we will look at is that you're doing that when we come out to visit. So one of the things is, are you bringing the right patients to the right place? Do you have too much over triage or too under triage? And so we'll look at, expect that your trauma center is looking at these numbers in one way or another, so that you're identifying that the right patients are coming to your center, and or not having too many patients coming to your center that shouldn't be. So that's something that we have you look at and you tell us about. In general, there should be a low diversion bypass amount, but we look at this as well, bypass diversion and closure. Do you have a protocol for when this happens, what happens to the patients? We expect that this should be infrequent, less than 5%, and that you have a policy and process in place. and also that the trauma medical director is involved and approves this process. Number 5, evidence-based care, and this relates to the trauma registry. The trauma registry is a requirement, and we feel that it's the foundation of the trauma center program. Without the registry, you don't know what's in your center, you don't know what's been happening, and the registry is very important. So there's requirements for the registry as to how to do it. And we try to make this as evidence-based as possible, not just the way we've always done it and therefore it's good, but evidence-based. So there's requirements for staffing, how many registrars do you need to adequately examine the charts that are needed and get the information out of it. There's information and requirements regarding billing, research, performance improvement, injury prevention, education, outreach, and clinical practice guidelines, which are all based on your registry. So you are expected to look at the patients in your center and develop things that are centered around this. Okay, number 4, injury prevention. So this is one of the requirements for trauma centers. They must have an organized and effective approach to injury prevention. And this is the idea that it's not just treating the patient after they've become injured, but trying to prevent the whole thing from happening. And again, this is localized information based on your center. What types of injuries are you seeing? What can you do to affect the change in this, in reducing injury in your area? So we don't prescribe how you have to do this, but we prescribe that you should be doing it. And then we examine to see how you're doing it. There's many examples, and I heard this morning how you have multiple processes in place already here. You have to prioritize these efforts, again, on the local registry and the epidemiology of your own data. An example that was required is the universal screening for alcohol, and it's required to be done in a trauma center on all injured patients. And this is referred to as the Screening Brief Intervention, SBIR. And this is something that after evidence came out that this was helpful, that these are patients that are in a time frame where they're often more acceptable to hearing this information, that it should be done. And so it was set out as a rule and went across the country, and I think many patients have been helped because of this. And this change happened very rapidly. So the decision was made to do it. It went into effect. Trauma centers did it. And rather than other processes which take much longer, the trauma was really a role model in rolling this out. And so again, it only affects the trauma centers that are undergoing verification, but currently that's a large number, and it's been growing. So I think when I checked it last, there were 532 verified trauma centers in the United States. You have to partner with other community organizations to get this injury prevention done. Many know this, they've been doing this, and it's useful. So again, injury is preventable. Injuries are not accidents, they can be prevented. And the staff can help with this if you have questions. You do need a clinical ladder for this process, and it's useful to perform this. I'm going to go on to number 3, outreach and education. This is also one of the expectations of a trauma center, more so in a level 1 trauma center, but it's important. And you have to engage both, not just your staff in the hospital, but the public and professional education. So it's an expectation, and again, we don't prescribe how you do this, just that you do this. Referral and access to the trauma center resources. There are many resources that we have that can help. There's a lot of educational material in the college, and these, just to name a few, that you're familiar with ATLS, which has been in existence for a long time now. But a similar program is ATCN, which is done in association with ATLS, and it's Advanced Trauma Care for Nurses. And there are other programs that are coming out that are also helpful. So education is important both for the public and for the professional, and outreach to the community. Okay, number 2 reason, patient safety and quality. And again, I talked a bit about this in the beginning, how there's been proven studies on trauma verification improving outcomes. But this is important. And one of the big things here is the Performance Improvement and Patient Safety Program, the PIPS program. And I've mentioned it a number of times, and the reason is it is actually one of the biggest problems we see and the biggest reasons that trauma centers don't pass their verification. If you have a insufficient process, or you're not taking it seriously, or you're really not looking at your problems, then that'll be recognized, and that's not the goal. The goal is to have you looking at your problems and fixing them. And this is, so it takes a lot of time. It takes a lot of time from the trauma medical director, from the program manager, but also the involvement of the rest of the folks involved. And I said we have monthly meetings and weekly meetings, and these people have to be engaged. They have to be engaged in not only identifying the problem, which is, studying your charts from the beginning, so you don't miss a problem. If you had a problem and you didn't know about it, you can't fix it. So that's the beginning part of that. Then identifying what the issues are, discussing it rationally with the goal to really see what you could do differently. And then that's what we're looking at, that process. And if that's in place, that's great. And if it's not, like I say, if people pass this over, this is the number one reason I think that trauma centers have trouble with the verification. The process measure, there are process measures, there's audit filters that you have that we look at all deaths to look for potential areas for improvement and significant events. So these are important things that will be picked up and discussed in the performance improvement and patient safety meeting. It's important to know what's happened in the past. Is something getting worse? So we expect you to track and report not just deaths, but complications. And then these are discussed in the Trauma Operations Committee, which is multidisciplinary, and the Trauma Peer Review Committee, which is also multidisciplinary, but is more protected and peer-reviewed, so that you can openly discuss the problem. So what was the reason something happened? And, you want input from everybody. You want input from each of the liaisons, the surgeons involved, and try to look for issues. So again, the physician liaisons, we require each of those highly involved specialists, neurosurgery, radiology, everyone involved with the injured patient to come to the meeting, and we require their attendance. And departmental leadership is important in this, and so we get these all together in the meeting, and it's a pretty robust discussion. And this includes pre-hospital trauma performance improvement as well. So if you identify a problem during this process that was even before the patient arrived, it's something that you can address. So that's the whole PIPS program, and again, it's a big deal for reviewers, it's a big deal for the hospital, and it takes a lot of time. But it's sort of the basis of how we get to issues that are local to your center and how you have worked to improve it. This has to do when we do a site visit with looking at the charts. So we will try to see whether we find things in the charts that maybe you didn't, or that you did, and how you address the problem. And so this takes a lot of time, and that's why the visit is a couple of days. And then lastly, I'd say that why do it? It seems like a painful process, but I think in general, when I go across the country and talk with people, they tell me that having become a trauma center that's verified has helped their program, and that it's the right thing to do for their patients, and therefore their community, and also for the trauma system as a whole, because it tends to help make things work together. So I'm going to summarize this and say that nobody said it's easy, but but hopefully it's worth it to go through this process, and that again, it's considered, the verification process considered by many to be the highest attainable standard for a trauma center, and that it does improve patient care overall, and that each department, division, and staff member has a role to play in this. So I'm going to end it here, and these are some of the references I was referring to earlier in the talk. And thank you very much for inviting me, and I'd be glad to answer any questions you have.